Hello everyone, this is Mary Gregory with MAS Coding Solutions. Hi, how's everyone doing? Welcome to our educational video for today, being brought to you by the Medical Coding Lounge, where we encourage coders to learn, to grow, and to connect. Our Coding Lounge is available. It is a platform for coders by coders, and I look forward and welcome you all to join. However, let's get into some education today. But normally I tell you how things are. It's a beautiful day here in Charlotte, North Carolina. That's where I am. I've been coding for 20 plus years. You probably can tell from the hair. I've always enjoyed coding and always will. I encourage you to, if you new to coding, I encourage you to study. I encourage you to grow. I encourage you to develop your critical thinking skills and not to worry about AI. AI can help you to be a better coder, but you got an advantage over AI. AI stands for artificial intelligence. You know what your advantage is? You human. You can think. You can think through things. And coders get paid to think. I just felt like I needed to say that today. You're much needed in this industry. I know that there are times when you're a new coder, it can be difficult for you to get that first job. But if you really want to be a coder, don't give up. Don't give up on getting that first job. Look in unusual places for that first job. Unusual places may be an insurance company. It might be an IT company. It could be a lawyer's office. It can be a billing company. Of course, we got physician offices. What about home health? Long-term care coding, acute long-term care. There's a difference between long-term and acute long-term. Let me give you just a brief definition. Long-term can mean a nursing home type situation. An acute long-term, we call them LTACs. Those are hospitals that the patient go because they still need a little bit of acute treatment, but not as much as being in an acute hospital. The average length of stay for an LTAC is about 30 days. And also you can think about critical access. So it's a lot of opportunities out there. I think the problem that we have is trying to find those opportunities. So I encourage you to network with your AAPC organization, your HEMA organization, and just with other people. Network even with your physician office. Who knows? They may know somebody that need a coder. Well, let's get started for today. Today we're going to be talking about safeguarding your coding. Recently someone asked me about safety. They said, how do coders have to worry about safety? And they said, if they have to worry about safety, what is it that they have to worry about? Well, I think there's two major risks that we as coders have to be concerned with. And those risks are overcoding and undercoding. Both of these can lead to serious consequences, such as claim denials, audits, compliance issues, lost revenue, bad data, a lot of it. And so we have to safeguard our coding from overcoding and from undercoding. So let's look at some of the steps we can take to safeguard our coding. And I know we probably get tired of hearing this, but it's education, education, education. Your education as well as physician education. And sometimes even axillary education. And you may say, well, what do you mean by axillary? You may have to educate your CEO sometimes as to what coders can and cannot do. You may have to educate the radiology department. What can coders do and what coders cannot do? Because remember, in order to code accurately, we use the entire record. And we have to understand the guidelines that is associated with certain areas that we can code from and cannot code from. So education would keep you sharp. It would keep you informed. Our coding guidelines, they really haven't changed a whole lot. There's a few times they updated guidelines. Several years ago, or maybe 10 years ago, they actually deleted a guideline. Okay? And so once they deleted that guideline, there wasn't a lot of education as to how to replace it. But you as a coder and myself as a coder, when they deleted that particular guideline, I think if you look back to I want to say maybe 2010, if you go that far back, you'll see where they began to talk about that particular guideline that was deleted. And it had to do with coding symptoms when you had multiple conditions that could be responsible for the symptoms. And so they deleted that particular guideline, and now we know we have to use the other guidelines for that. So you want to constantly be educating yourself. How are you going to do this? Well, you're going to go to seminars. You're going to listen to webinars. Now, you may have a particular area of coding that you do. Of course, you may spend more time in that area. But if you are what I call a multi-specialty coder, then you're going to have to look at several different or educate yourself with different webinars and guidelines. Always keep abreast of what changes are being made in the ICD-10-CM. If you're an inpatient coder with PCS guidelines, coding updates, and of course, CPT is for outpatient. Stay involved with your community. Get involved with, I'm thinking about, sometimes people have these, not necessarily debates, but meetings where we get together and we talk and you bring up issues. And a lot of times issues may come up, or a coding scenario may come up, and you might have the answer to that coding scenario. So stay involved, stay educated. The next way we protect or safeguard our coding is we are also part of we're responsible for protecting the data. We're responsible for keeping PHI secure, the protected health information. So that means that you got to learn how to use your password accurately. Don't open up unnecessary emails or emails that you are not familiar with that person. We want to follow the HIPAA guideline, especially when it comes to coding. We know we can only code from ICD-10-CM, PCS for inpatient. Outpatient, we do ICD-10-CM, and we do also do CPT for outpatient. The dental guideline, dental coding. So we have those guidelines that we have to follow. Even though I always feel like this is such a burden on me and it takes times out of my day, but we got to participate in that cybersecurity training that we get from our organization. And so once again, remember, security is part of your job as well. Don't think your job is just coding, but you are also responsible for helping to protect the data as well. And then this one here, I feel like I hate auditing. I hate being audited. Let me put it that way. I perform audits, but I hate it when people have to come and audit me. But guess what? It's a good thing. I can learn from audits. I don't care how long you've been coding, you can learn. And you must always be in that learning mode. Will you always agree with the auditor? No, you won't always agree with the auditor. And sometimes you can present your case, and that auditor can change what they say. But auditing help us to reveal to us when we're overcoding and when we're undercoding. And you might say, well, Mary, what are you talking about when you say overcoding? That, to me, can be several different things, but one of the biggest things I think about is coding a diagnosis that's not clearly documented, or it may be a questionable diagnosis, and it increases your reimbursement, be it inpatient or be it via CPT. It increases the reimbursement. So now I have overcoded because I don't have documentation to support that code. Or the guideline may tell me, do not use this code with this code. And if I do it, then I got a compliance issue. Sometimes the issue with overcoding may not necessarily be an increase in reimbursement, but it's a compliance issue. Also, the when you have auditing, it helps us to identify problem areas. When you go through an audit, sometimes you'll find out that coders can have the same diagnosis and be coding them 2 or 3 different ways. And you'd be like, whoa, wait a minute, how did you get to that code? And the other person, well, how did you get to your code? And so it helps identify those areas as well. And like I said, it'll help you with a pattern. Maybe someone don't know how to code. I can remember several years ago where we had an issue with one of the hospital I was working in with pacemaker coding. And especially when we went to ICD-10. And because when we had ICD-9, we had one code for the revision. But when we went to 10, there's several different codes you may have to use to get the pacemaker revision correct. Because when you do a pacemaker revision, you got to know, what, did you remove the old pacemaker and replace it? Did you just remove the leads and replace it? And so we had some coders doing some different things. So it helped us to identify those areas where we had coders that was, we had some patterns going on that wasn't correct as well. And remember, auditing don't just educate the coders, it also educates the physician. Because we all know we can only code what's documented. Now, of course, it's our responsibility to be able to understand that documentation, especially when it comes to procedural coding. And so when the documentation is not clear, and we don't go back and get that clarification from the physician, or the physician may think, well, I don't understand, take the area of post-op complication. See, post-op complication, when a physician said this is a post-op atrial fib, is he really saying that atrial fib is related to the procedure? Or is he saying that it's in the post-operative period? It's in that time frame of when the patient have had the procedure and now they're in a recovery phase. And so sometimes you have to educate the physician and say, well, we want you to understand when you say post-op, we may have to have that clarification. Are you just saying this is a time frame that the patient in versus if this condition was truly related to the surgery? And another big area is history of. Oh my gosh. History of. OF. You got a history of. What does that really mean? Sometimes we have to educate our provider and we'll find out maybe in a coding audit, hey, the physician said the patient have a history of cancer, history of lymphoma, but they still under treatment. Well, what does that mean? When he said history of, and the patient may be currently under chemotherapy treatment, that's not a history of. The patient still have cancer. They're still being treated for it. And so we have to educate our physician how to document certain conditions, not for reimbursement issues, but for compliance, for accuracy of the data. So I just wanted to, one of the things I had to come to terms with in my own life is that auditing should not and is not a punishment tool. It should be a learning tool. Now, you may work in a area where they kind of use it as a punishing tool, but don't take it personally. Don't let it be a punishment tool to you. Let it be a learning tool. Learn from it. Grow from it. And like I said, sometimes the auditors are not always right. We can be wrong too as an auditor, and it's okay to plead your case, but plead it respectfully. Show some respect, okay? This pretty much going to end this presentation on what we call safeguarding your coding. Stay accurate and stay compliant. Some things I want you to remember too. Documentation is everything. And I know physicians especially get tired of us saying, well, if it's not documented, it's not done. But documentation is everything. And we can only code what is documented. as a coder that's been coding many years, I have a tendency sometimes to want to read through the lines, sort of they say see through the lines. But guess what? I always have to take it back to the physician if I feel that, are you really trying to say this versus that? But the one thing I have to be very, very careful, because physicians don't mind telling you this. You do not have a license to practice medicine. And sometimes they can get that feeling from how we present a query to them, how we present the question to them. So be careful with with presenting queries. You never want the physician to feel like you're challenging them or that you know more than them, because we don't. We don't know more than the physician. So you want to be careful with that. So we can only code what is clearly documented by the provider. And we have to get the provider on board with that. And they're getting to be more and more acceptable, I think, to coders and or CDI asking questions. But I also feel sometimes we create way too many queries. We are creating, I call query physician fatigue and or death by query. Don't be a query queen. Know your guidelines, know your rules, have critical thinking skills, how to put the documentation together with the rules, and when you are not sure, do your homework first. Before you go back to the physician, you go out and you study whatever you need to study to see if you get an understanding about that condition before you create an unnecessary query. The other thing is always follow hopefully your organization, physician office, be it hospital, whoever you're working for, have some consistent written coding policies. A lot of times the coding policies can come directly from the coding clinics, or they can come from the official coding guidelines, but you want to have those policies. Having those policies, being able to go back to the policy, will ensure that you have accurate support with quality assurance. And remember, you are always coding with a purpose, and coders get paid to think. Continue to follow me on LinkedIn, Facebook, Instagram, and TikTok. And our website is www.mascodingsolutions.com. You'll also find some information about our medical coding classes. We have now partnered we are full force with the AAPC. We're using their Blackboard platform, and we are offering Medical Coding 101 that will prepare you and help you to pass the CPC examination. I look forward to talking to you in the future. Feel free to reach out to me at any time via our YouTube channel. Thank you. How was that?